Sara, when you were describing Providence and your charter there, you were talking about long-term visions. As a strategic leader, what do you see as the main charter as we move into 2030?
A lot of health system work has been focused on care delivery. I would call it sort of like the last mile of care delivery. And that's a really important mission and reason for being. But as we look forward, there are lots of folks doing that kind of work. Lots of health systems doing that work, lots of non-health system providers doing that work. There are new companies emerging every day. Insurers are getting into care delivery. Retailers have tried their hand at care delivery. There's just a lot of activity out there. And in fact, a responsibility that we have to our communities, as well as potentially a lot of other health systems, is this responsibility to earn the trust as like an integrator in the communities that you serve and support and empower patients and consumers in that process of navigating all of this. It's a vision that has multiple components, but ultimately it's about creating an open ecosystem.
Hello, everyone. I am Chris Hemphill, your Meeting of the Minds host. And to kick us off, we're going to hear from the great economist, the great healthcare economist, Dr. Uwe Reinhardt, who posed a powerful question. Should the child of a poor American family have the same chance of avoiding preventable illness or of being cured from a given illness as does the child of a rich American family? That question is powerful because it forces us to think about our policies in the shoes of the people that they impact. So we can do the same thing when we think about our technology policies. With this question, should a child or patient suffer more because critical parts of their health records are scattered amongst competing organizations? I think that everyone would naturally say no, but then they would pause and say but. And among those buts are going to be some very powerful things like technology limitations, data sharing, incentives structures, and etc. But Sara Vaezy, who you see on my screen here, who's Chief Strategy and Digital Officer at Providence in the Pacific Northwest, she isn't going to let those buts stop her and her team. Her strategy right now and going into 2030 is to break down those barriers. And with this Meeting of the Minds, we hope to give you a blueprint to be able to do the same within your organization. So kicking us off, Sara, could you talk to us? Could you tell us how you're doing and just give us some background on Providence and some of the goals that you have today?
Absolutely. And Chris, I'm so excited. I think you told me that I'm the first repeat guest on Meeting of the Minds. So I am super excited that I get that honor. And thank you for having me. As you noted, I serve as the Chief Strategy Officer and the Chief Digital Officer at Providence. And what I have, responsibility for across the system is a variety of different things, but really focused on positioning our health system to sustainably deliver on our mission into the future. And that's through things like our corporate strategy, which is focused on what do we want to be, and really having long-term thinking, like not just, sort of in the spirit of the Sisters of Providence and Sisters of St. Joseph and all of our, foundresses that started the organization over 170 years ago. And so having that sort of long-term thinking around where we want to go, who we want to be in terms of serving our communities. And then I'm also responsible for sort of driving sustainable growth for the system, meaning like reaching further into our communities, providing greater access, and doing so in a sustainable way through things like marketing, our digital experiences, innovation in the digital domain, and patient experience. And then finally, really focused on care model transformation through things like virtual care and digital health partnerships. And you'll notice a lot of like the themes that I'll talk about is around partnership. And I know it gets back to your initial prompt, which is like, if we really get to the essence of it, like how do we deliver the best care in what we think is going to be an increasingly sort of federated, fragmented system of providers, of services, of all these things that we put our patients and consumers in an unfortunate position of having to navigate on their own. So, we're really focused on those types of things.
Well, Sara, I'm so happy that you're back. Yeah, and yes, you're 100% right. This is the first time that we've had a repeat guest on Meeting of the Minds. Honestly, when we shut down the phone the last time, the first question was how do we get her back, because there was so much energy and electricity around that first topic. I don't know if anybody is a repeat guest, but that first topic was, are digital health leaders an endangered species? Obviously a resounding
That's
no.
Well, you never know. I mean,
Yeah.
time will tell.
Along with that, and honestly, sorry, I wasn't even going to talk about this, but I told a friend that you were going to be hopping on this webinar, and the first question that he had was, "Oh, is she also the hot pepper entrepreneur?" So can you talk to us about your true main hustle or side hustle, however you decide it, your pepper hustle?
My pepper hustle. Yes, I'll talk a little bit about the pepper hustle, which is that we have a very small family run interest in hot sauce that's tasty and enhances your food instead of takes over it and is good for you. And so I I eat, I mean, it basically comes down to I eat a lot of hot sauce and I really like hot sauce. And I do think it's good for you as long as it doesn't have any chemicals in
So we're going from habit to hobby to
it.
business to
Health.
enterprise to
Yeah.
empire. Well, good to hear from you. And like I just saw, Woebot just said, "Hey, speak to the chat and everything like that." Just as a reminder, if you're listening to this on a podcast or like anytime after the great fine day of August 22nd, 2024. You missed out. You missed out on the opportunity to sit down and hang out with Sara live. So make the most of this opportunity if you can. Chat back and forth with us. We're here to like we have some questions that we've peppered into this conversation, but we're also we're also 100% open to your questions in the audience. So folks listening to this later, that's your reminder to go to wobot.health.com/meeting of the minds and subscribe, so that when it comes to your favorite healthcare leaders, suggest them to us, and at the same time, never miss a conversation like this one. So jumping into it, Sara, when you were describing Providence and your charter there, you were talking about long-term visions. As a
Mhm.
strategic leader, as a digital leader, as all those things, what do you see as the main charter as we move into 2030?
Um, I think that, and you and I spent some time talking about this as well, which is that um, when we look back, a lot of health system work has been focused on care delivery. I would call it sort of like the last mile of care delivery, which is, and doing it ourselves. And that's a really important mission and reason for being. But as we look forward, and I referenced this sort of in the opening, is that there are lots of folks doing that kind of work. Lots of health systems doing that work, lots of non-health system providers doing that work. There are new companies emerging every day. Insurers are getting into care delivery. Retailers have tried their hand at care delivery. There's just a lot of activity out there, and it's not like a monolith, right? There's hospital care and there's specific service lines within hospital care. There's ambulatory care. There's mental health care. There's physical health care. There's dental care. There's all of these things that sort of culminate in the health of an individual, and that's not going to go away. And so what we see, our vision, and in fact, a responsibility that we have to our communities, as well as potentially a lot of other health systems, is this responsibility to be to earn the trust as like an integrator in the communities that you serve, and support and empower patients and consumers in that process of navigating all of this. It's not, and being a good partner in getting that out into the community as well. And so, and then of course, like, this doesn't, it needs to be accompanied by a, rational economics and operating models that work, and uh, and data continuity and experience continuity and all of these things. So it's like it's a vision that has multiple components. But that's what we're working toward. And we have some examples of that. But ultimately, it's about creating an open ecosystem. It's not just about being a closed off walled garden of we do everything and that's it. Like at the highest level, primary care access challenges across the country have proven that that's not possible. And so we really need to be able to tap into what's already out there and connect the dots for our patients and our communities. That's, I think, the ultimate vision. And then there's other aspects of it too. But yeah, I would start there.
Well, that fantastic way of wording it. And I've been asking healthcare leaders over the years on, hey, what needs to come together to make these things happen? Because again, the answer isn't no, we shouldn't be interoperable. It's no, but, and there's these hurdles that you just identified. So we're seeing that move. Like one thing that you said earlier in a previous conversation was we need to stop thinking of ourselves as closed ecosystems. So knowing that it's always been important to have these connected systems that enable people to get the type of care and the types of access to information that would improve outcomes. What's made it a priority now?
I think that one thing is that we're in a good place. I think we've made a lot of progress at the sort of standards and interoperability, like data interoperability kind of level, which is really positive. So, for instance, through the 21st Century Cures Act and through TEFCA and other sort of regulatory vehicles, like we're making progress around interoperability, and we're doing so in a standards-based way so that it can really facilitate data exchange, data services, and then the translation of those things into usability by the relevant provider communities and other sort of service providers. So I think that that's one of the reasons why we're in a different spot now and we're in a good place versus where we were. I also think that 2022, and I think we talked about this a little bit in our last discussion. 2022 was a really tough year for health systems, and it actually, I mean, it was a tough year for providers in general. There were a lot of workforce challenges. There were a lot of supply chain challenges. Inflation was going up at a rate that we hadn't seen previously. And so what it created, for lack of a better, I don't really like this term, but like the burning platform, right, for change in a way that that maybe we hadn't quite felt in the past. But I think that we recognize that that we need to do what we do best, partner with others where they can do it best, and then and like right, the thing, one of the things that bothers me the most is multiple players all trying to do the same thing and stepping on each other versus like adding value
Mm.
to a community, and because of the like, to say it crudely, like supply challenges, we don't have enough people out there to care for everybody that needs care. The industry is moving forward in a way that's like different. And so we're thinking about it much more wisely now. Like, let's use the capacity that exists. Let's partner with one another. Let's share data when we, before all we were doing was playing a game of chicken around each other's data, right? So the market has evolved, the underlying data and regulatory environment has evolved, and we're still in the early-ish stages around the silver tsunami, and so we still have some opportunities to transform. I worry if we don't do something now and in the next few years, like Americans and their access to care is going to become increasingly constrained. And we can't afford to do that.
You know, a lot of what I'm hearing from you is that, hey, we've been wanting to address these challenges, but because of changes in the way technology is distributed and the way regulations are looked at, there's now a knowledge and acknowledgement from these higher perspectives and upstream perspectives that
Yes.
enable us as operators, right?
Yeah, I think that's a really nice succinct way of putting it, which is that um, we've we've put a lot of the building blocks in place, and now that's raised the level of urgency from the top. And when I say top, I mean like from federal government or from regulators, uh, to put that in place, and from the top at a health system level to really make that change, and engage more productively in partner discussions.
Now, just want to address the chat. Everybody in the room, really happy that you're here. And if you have any thoughts or there have been initiatives or moves down this direction that you have questions about based on what Sara's doing, drop them in and we're happy to address them. Along with that, I'm going to say that we have an unpublished conversation. We haven't released it yet, but we were speaking with Dr. Mickey Tripathi, who is the
Awesome.
yes, yeah, the office of the National Coordinator for Health IT. He hates that long title, but I'm using it anyway because how else would you know who I'm talking about? But key on his mind, we asked him like, if you have a magic wand, what would you change? And it was all about making sure that we have the incentive structures in place that we can deliver care in a connected way. So future, big picture and everything like that, we have the backing. Can you talk to us about Providence current moves in this direction?
Yeah, absolutely. So we're doing, I'll break it down into like a couple of areas. One, I'll talk a little bit about from an operational perspective, how we're moving forward in terms of partnering proactively. The second piece I can tell you is a little bit about like the work that we're doing around data and bringing together and really connecting the dots when it comes to data. And then third, I can also talk a little bit about what we're doing on the technology side, in particular around like patient and customer experience and enablement of a personalized experience that is relevant to individuals and helps with that dot connecting and that empowerment that we've talked about. So on the operational side, what we've done is really look for partners in specific areas where we think, for instance, that they can perhaps get to scale better than we can. And revenue cycle is, for instance, one of those areas where we've partnered with R1. Revenue cycle over the years has gone through this like big transformation where, and this is not just a Providence thing, but has gone through a transformation where, you know, every hospital had its own revenue cycle, and then like systems brought together a revenue cycle and did it on their own. And then they started outsourcing bits and pieces. And it was very much like outsourcing as opposed to like a partnership like relationship. We partnered with R1 so that we could actually have like not just a better, you know, P&L like performance,
I'm
but we could
sorry.
have a better. Oh,
Can you tell us who is R1?
R1 is a revenue cycle company, and one of the big ones. Like there are a handful of big revenue cycle companies in the country, and R1 happens to be one of them. Um, and uh, and so we worked with them to say like, how do we actually create, for instance, like contact centers or call centers that really help our patients like understand their bill or work through a financial experience in a really positive way that we can wrap around with things like financial assistance and counseling and things like that. So that's one example. We've also partnered like with LabCorp around reference labs. So we're not doing all of our own reference labs in all of our regions anymore. We've partnered with a national organization that can do this at scale and really knows the lab business like inside and out. We're also looking at partnering in a lot of the post-acute domains. And so, again, focusing on organizations that really know post-acute care and can work with us to extend that kind of post-acute care into our communities. We're actually based in Washington State. One of our big states that we operate in is Washington. We're also in 6 other states across the country, across the west coast of the country. Washington suffers from the most like underbedded status, if you will, in the post-acute side. So we're really proactively trying to find partners that we can tackle that problem with. On the post-acute side. So all of these are examples, like on the operational side, ways that we're looking at extending our ability to deliver care through partners. And then on the data side, we're doing a variety of different things. Of course, we've invested in our own data platforms and knit together a variety of different data sources to help us make really great, decisions internally for the sake of our own patients. And that's not limiting the data to exclusively, again, our own environment, but bringing in partner data to make sure that we can do that. Partners can include payers and medical groups outside of our own environment and other providers. We've actually also integrated, for instance, our digital data. So we know if you are searching for back pain on our websites and you are a patient that is known to us, you've come to us before, like we can actually reach out to you and say, hey, like, do you need to come see somebody? In a non-creepy way, right? So we can really like create that like actual like personalized, guided wraparound experience. That's all internally focused. And then we've done a lot of work with consortia of data. So we're part of Truveta, which is a data consortium of, I believe there's now 34 health systems in this group. Excuse me. And we're all putting our data there and using it to inform rare disease research, clinical trial research, and a variety of other use cases that you really need that sort of aggregation from multiple systems to do a good job. And there's a huge equity implication to that too. So, we want to make sure that there's geographic variation. There's variation in terms of the data that's in there around patients with different socioeconomic status, different racial and ethnic groups, different, so we want, like, instead of sticking with like, a very narrow demographic, which a lot of research in the past has actually been focused on, like, we think that there's an equity imperative associated with bringing a lot of different data together as well and utilizing it for a variety of purposes. So Truveta is another example of that, and a really strong partnership. Yeah, well, we're trying.
Yeah, there's a strong history of trials that aren't informed by diverse populations and groups. So
exactly.
Yeah.
Exactly.
And I'm going to point a little. Like, you just reminded me of some recent research that was led by Dr. Athena Robinson on our team. That is a meta study of racial diversity and other types of diversity and inclusion among trials. Marissa, on the links, I don't know if you have the link to that paper to drop, but we'll make sure that that's included in the show notes as well. So, sorry, you reminded me.
No, that's a great example. That's a great example. And then on the technology and like patient experience side, one of the things that we've been working on is, like, we know that on average, even the patients that come to us are also engaging with, like, on average 5 different health and healthcare companies per year. For a variety of their different needs. And that if we only stick within our own very narrow sort of lane, we're going to miss a big part of the picture, right? And so we went down a journey of what we call identity-driven personalization, and basically that's knowing your users, knowing your patients and consumers in a broad context, connecting it to the clinical record when it makes sense, but then also federating the identity of that individual to all of the partners that are relevant, and then bringing that all together in one picture. And this kind of gets back to your initial point around, like, how do we ensure that the things that an individual needs to optimize and maximize their health are provided to them in a single access channel and in a personalized way so that it's relevant to them. They keep coming back because they know that is we've earned the trust again to provide that navigation service for them. We actually built a company around this and spun it out earlier this year. And what we're doing now is we've compiled, this company has compiled an ecosystem of a couple dozen partners and growing. And it helps Providence to deliver personalized experiences across our logged in digital channels to our patients. So we're connecting the dots for them.
And what's the name of that company? We don't consider it like an advertisement or a pitch. Just curious.
Okay, I was trying to be sensitive to that, so thank you. The name of the company is Praia Health, Praia, and I'll tell you just a fun story. That Praia del Norte is a place in the world where there are the biggest beaches, the biggest waves, and the reason why there's these huge waves is that there is, and this is the physics nerd in me coming out, so you're going to have to bear with me for just a second. The reason why there are these huge waves is that there's a big trench that kind of runs alongside the beach. And the trench causes the molecules of water to have interference, like destructive or constructive interference. And basically, like, these molecules of water crash together and make these huge waves. And we see that trench as this deep source of data that we can use to drive personalization and real value to patients, in the form of like this wave, this wave of like goodness that comes at them.
Next time, if I ever start a company, I'm going to ask you to name it, because that's a much deeper story than I expected there.
I assure you, it's literally the only time I've done it successfully. So I don't know. I don't have a very good track record.
I'm seeing a question down here from Ozer Abajwa. Great. First of all, great to hear from you, Ozer. And also, the question is, for interoperability, are you leveraging HL7 FHIR APIs? What's your overall interoperability landscape and vision for semantic interoperability?
Well, that's a very sophisticated technical question. But what I will say is that, like, we're using a lot of, a lot of what we build leverages the FHIR-based APIs on Epic, because we are an Epic shop. We also use HL7. So we're leveraging all of these standards-based approaches to exchange data with partners in a responsible way, according to like the appropriate kind of principles that we have, which is, one, for instance, everything that we do is stateless. So we're not like sending data somewhere. We're not hosting data separately from from our own cloud instance and those kinds of things. So we're doing everything like in a very compliant way that's also interoperable. But it's a broad landscape. We're also looking at, like, our journey into TEFCA and the requirements is still underway, right? So we were actually, for instance, Epic had their user group meeting this week, and we spent quite a bit of time talking about TEFCA at that meeting, and like the requirements of TEFCA that are ever evolving to ensure that data is both interoperable and remains secure. So I think I would say we utilize a variety of different mechanisms, and it's changing every day. A lot of, like, I'll also say, like, we're exploring areas in, for instance, value-based contracting and how we can exchange data via HL7 with payers around value-based contracts and the supplementary data that is required for them to process claims and value-based contracts and things like that. So it's a broad landscape, and we're doing a lot of different things. We're hopeful that, like, more and more types of data will be covered by standards, and types of things that we will be trying to accomplish. For instance, like, we focused a lot on transactional type things like appointment booking and messaging and things like that with providers. And not all of that is standards based yet. So we're hoping that the breadth of that, like the scope of those standards based elements, increases.
Beautiful. And while you're talking, there a question about the Epic user group came up from
Okay.
Rory Burrill, who I have the pleasure of working with. But his question in the chat is focused on your views on the role that Epic and others are going to play in this move towards more open healthcare standards. I saw a good question around patient-facing AI and the ownership the ownership of EMR versus a health system in with regards to patient data.
I to go to the question around like what is the EHR company's role in these in interoperability efforts and standards based efforts. A couple of things. They are the in a way like they are the primary infrastructure for holding and exchanging that data. And so I think that they need to, and they are leaning in to make our data as available for the purposes of interoperability and all of the kind of tasks that we try to complete and the activities that we need to base off of interoperability. They need to make that as easy as possible. I think part of that is ensuring that we have as many standards that are well documented as possible, that there's depth around the utilization of those standards, and that when they are implementing something, that they're implementing it not like in a standardized way. So for instance, like one area that we've spent a lot of time on is in identity, and OpenID is a big area of effort to ensure that like a single patient can have an identity across multiple entities, right? So that is one area where we think that they need to lean in and ensure that we can do identity management and identity verification and account creation and all of these types of things in a standards-based way. So they are the infrastructure that needs to really be as open as possible with the appropriate controls and mechanisms to keep data secure. And let it be used appropriately. Now, there are nuances to that, of course. And one of the things that they talked about at the user group meeting was the evolution of TEFCA and what had happened a few months ago with particle health and what they're learning along the way in terms of some of the challenges of interoperability and stewarding data in a secure way. So I think it's not an easy answer, but they do have like an obligation, I think, to lean in and to create open standards.
Now, I want to get into some of the implications of these open standards, data that are newly available and things like that, because it ties back to your charter to 2030 is we have to earn the trust between not just between the organizations, but also the clinicians who are directly delivering care. So when it comes to these new sources of information that clinicians might see from entities they might not necessarily be as familiar with, what can you talk about the clinician experience and how we're driving adoption among them to accept these new data and implications coming in?
Can you reframe your question?
I can try.
Make sure I understand it.
I can try.
Or just repeat it. I'm still thinking.
Really, well, one point that you had made was around these technologies that are connecting systems and making more data available. And I was wondering if like clinicians are often feeling deluged by the amount of data that's coming in, and just wondering about how we go about earning the trust of clinicians and getting them to act upon some of the newer data sources that are coming online.
So it's an interesting question. But by the way, I would add one thing is like on that earning the trust piece, like we have so many different stakeholders, and one of the most important uh, like partners that we have to earn the trust of is the patient. So I would add them to the mix of that. Um, as it relates to clinicians and the deluge of data that they have to deal with, and frankly, like I think it was really interesting. One of our in a recent clinical AI meeting, our clinicians were talking about how finding relevant data is like looking for a needle in a haystack. Like nobody has the opportunity to look through this massive amount of data in a patient chart every single time. And so I don't know if what I would say is I don't think that all data, one, is created equal. Two, is valuable in terms of a specific uh, uh, context. And so contextualization of data is really critical. So, for instance, like, and I'm gonna, I'll probably butcher this, but one of our clinicians at Providence has developed a technology called MedPearl, and a big part of MedPearl is one taking best practices like clinical intelligence that's out there and combining it with clinical context about a given individual, so that in a specific instance where you know the patient is going through XYZ, the relevant pieces of that massive chart are being brought forward. So they don't have to do chart digging and they don't have to do those types of things. So I think there's one aspect of it is that, which is we need to work on contextualization of all of the relevant data. Not all of it is relevant. And frankly, our clinicians don't have the time to go through it all anyway. This is also where AI, and in particular, or not necessarily generative AI, but large language models have a lot of potential to do the appropriate summarization. And now we've got a long way to go, and we still have to keep a human in the loop on all of this because we can't fully rely on AI to do summarization with 100% veracity and 100% accuracy. And so folks still might have some hesitation and worry that something's being missed, right? And so there's a lot of that, but I think that there's a tremendous amount of potential there to support contextualization, summarization, et cetera. And then there's all of this other data isn't necessarily needed for the clinician, the individual clinician, but when it's mapped up against a system that's got operational rules and business rules around, for instance, like who needs to have their gaps closed and do that dynamically, who needs to their care gaps closed, who may have an opportunity to engage in a third-party program around diabetes prevention, who might have an opportunity to engage with a third-party program around mental health, right? Like, and doing that in a dynamically rendered way, it could just be useful to the patient. And then having some loop closure to say, hey, the patient did or didn't open this, is engaging, is not engaging. I think it doesn't all have to go back into the EMR. It's not useful. And so I think like we have to be very judicious about that.
That tells a really good picture because I've been counting the number of times that we've uttered the term big data here, and it hasn't happened once until now, until this reference. It's not about getting as much data as possible and hoping that it has some value. It's understanding the context that clinicians and patients are operating in and making sure that there's workflows and processes around the specific elements that we're trying to surface. That I'm just guessing. That's my human summarization of what you said. But how far off am I?
Yeah, I think big data is like our chief of medical analytics says something really brilliant, and he's a brilliant guy, and so what he says is, we may have data superiority, but do we have decision superiority? And that's what we're ultimately going for, right? And so, just like having more data without some sort of actionability around it is not useful. You have to be able to take an action. There needs to be some intelligence there. And I think that's some of the really exciting stuff about this new wave of AI is that it allows for that actionability. Um, because of some of the underlying nature of like its ability to um, summarize, its ability to contextualize, its ability to um, uh, even generate generate responses and actions, all with a human in a loop.
Well, let's dig in a little bit deeper on that too, because another stakeholder that you referenced is the patient. And I've been at conferences where people have spoken up and asked, "Hey, how do we earn patient trust?" And you gave an example of someone on a website on an experience that they might think is disconnected from other aspects of their healthcare. But as you're tying those dots together, it has to be done in a way that's trustworthy and, as you said,
Mm-hmm.
and as I will say, non-creepy. So how do you strike that balance and earn the trust of that most important stakeholder in the loop?
You know, I think usefulness, like we tend to get a little too fancy with it in some ways. It's like usefulness, relevance, um, making their lives easier. Like those are like very basic things, right? And we actually had this like amazing piece of feedback that we got about the Providence app, which is, powered by Praya, which is that company that I was telling you about earlier. And I'll actually like even read you all the quote about from the patient that we got, and it was really about how the app like helped ease their way in a really difficult situation. So I'll read it, and here's what this person said. I'm unable to vocalize right now due to cancer. The Providence app is perfect with the messages area. It takes the frustration out of trying to make appointments when people hang up on me because they can't understand me or I can't speak loud enough to be heard. I can refill my meds, make appointments, get test results, converse with whomever I need to. And it's super powerful because it's just useful. It's useful to that person. It makes their life easier. They get what they need to get done. That's how you earn trust. Is like I could weave all sorts of tales for you, but unless I'm actually making your life easier, then I'm not doing my job.
Well, that's a big reminder of like if we're caught up in a slew of technical details and standards and everything like that, like it's good to be able to come back to the surface and be reminded that this patient didn't necessarily know about all the
Totally.
data pipelines and things like that went into enable that experience, but this is what they're saying now that they had it.
Exactly. And, there's this concept of like sort of technology transparency, which is that you almost don't even recognize that the technology is at work, right? In the case of AI, whether we like it or not, it's pervasive. There are elements always working in the background to do specific things. Hopefully, those are things that are good for people and not not the other way around. Um, uh, and it's sort of this like um, like you almost don't even recognize your smartphone as something separate from you anymore, because it's transparent. It's just there. It just helps you get stuff done, right? And an iPhone may not, or a smartphone may not be the, like sort of right example. There are obviously a lot of um, downsides of it, adolescent mental health being a really big one with social media. But transparency of technology is an important thing for us to consider. You exactly described it, Chris, which is like patients don't care. They don't care that LabCorp is doing your lab and XYZ medical group is the where the doctor is, affiliated, and that the hospital is, Providence. They just want to get their stuff done and get care and get better or stay healthy or whatever, right?
100%, 100%. So it just makes me think about like all the entities, everything that you're talking about coming together. We were talking about different provider organizations, the relationship that you and multiple organizations have with payers, and an entire ecosystem of digital health tools. So much like I know that you didn't just walk in and hit an easy button and boom, everybody, all your peers agree to having this integration, or maybe it was a simple conversation, but I'm just curious about how you sold and pushed for this type of connectivity, this type of ecosystem, how you're sharing that within the organization and getting other leaders on board with all this connectedness.
Well, one comment I would just make is that when it comes to like the overall interoperability journey that healthcare needs to go through, we collectively, as Providence, as health systems, as providers, we are at like mile point two of a marathon. So we have a tremendous a long way to go. Um, as it relates to, like, for instance, what we did on the patient and consumer personalization side of things, we really just started to articulate the need to make a really we articulated the need for our patients to have a place to go when they had complex needs. That was the case that we made. And if they've got appointments and medications to refill and financial assistance, like, how do they navigate all of this? And what is our role in, if we don't do it, they'll go somewhere else. And so that was the case that we started to make. And by the way, it's not just about plopping all of that stuff down somewhere. It's about, like, it's not a repository, right? Like, no one wants to go dig through a box of things. You want it to be presented to you in a way that is easy for you. The Providence promise is know me, care for me, ease my way. The easing their way part was the way that we really said, this is what's going to keep people in having a relationship with us. Otherwise, we're going to lose them, because, like, why would they want to make life difficult for themselves? And so we built the case up from there. It really started with the patient and the need for us to do that, to ease their way. And then, of course, there's, a financial case to be made for why that's important. There's, by the way, there's also an operational efficiency case to be made for that. I'll give you one example, which is when we put in this mechanism for identity creation and verification and synchronization to the clinical record. So making it really easy for someone to create an account with us and connect it to their clinical record, their MyChart, if they had one. We saw an increase in the number of accounts that were created and a decrease in the call volumes to our contact center. And the reason for that was the account creation process was easy. Now, we had a lot of bumps, and we actually had, we have definitely made some mistakes along the way. And at one point we saw a huge spike in call volumes because we screwed something up. So it hasn't been a linear or perfect journey. But we've seen now, as it has stabilized, sort of a better experience for the patient and an efficiency case for the system.
Well, I got a reference just like you're talking about the reasons to do this and how it's not just plopping down. And it just reminds me of a recent conversation that we had with the CEO of NovaWell, Suzanne Kunis, who said, do the right things and the money will follow. And it just reminded me of a little bit in this earlier in this conversation, as there's incentives and now technologies that lower that barrier to entry to being interoperable. Now you can be more positioned to be able to do what's right by patients and be incentivized for that.
Yeah, and our dream, and we have some of the technical infrastructure for it. We just need to build on the data exchange pieces. Is that, like, we can actually do single sign-on across Providence and our partners. So you don't have to have different logins. You can have a federated experience, just like if you, folks can sign in to a variety of different places with their like Apple ID, right? It's the same concept. And you don't have to memorize like 150 different passwords. You have the one and you can connect the dots. So for instance, we do work with Omada, which is a diabetes prevention provider. and they do hypertension and a whole host of chronic disease kind of management. And we're working on, the first step was we can show folks who are eligible the Omada program in their experience, their Providence experience. The next step would be, can we actually sign them in single sign-on, right? Even though it's a separate provider, and do a bi-directional data exchange. So there's, and then imagine if you could do that across any third-party application or with your payer, your insurance company. That's the direction that we're ultimately heading.
And one direction, like you're on a podcast at a digital mental health company, so I have to ask about that perspective. But it's not just that; it's just the fact that interoperability is much bigger on the table. Finally earned its seat at the table that it deserved way long ago. Same thing is happening with mental health, and I'm curious about these coming standards and changes and things like that, and how mental health factors into the strategy at Providence.
Mental health, it's kind of funny. It's like, I find the separation of mental health from physical health as ridiculous as the separation of like dental health from like the rest of your body. It's like, is your head like, you should put it over here and then your body goes over here? Like, it doesn't make any sense. And so, our direction is treating people as whole people. We may not do dental care, right? We may not deliver all of the mental health. Like, we have natural limitations to the services that we can provide, primarily through capacity, right? But the whole point of that is that we're developing like sort of and our mental health team is working on this, a comprehensive mental health strategy that, one, supports our primary care providers in an integrated behavioral health model, and then extends into other solution providers to provide a variety of other services that we're not necessarily going to be able to do all of it ourselves. So it's completely a part of this whole notion of moving toward whole person orientation, versus just carving up the body in these like weird ways.
Couldn't agree with you more. I didn't know whether the clap raised the roof or whatever. Like, I'm showing my age by raising the roof, but couldn't agree with you more.
I know what you're referencing.
Some of my coworkers don't know what I'm referencing with that.
Oh my gosh.
But there's a question that I think is kind of a wraparound of this conversation. And you have been very humble as a representative of Providence to say there are things that we're not the best at that we seek to have served by other entities. So there's this question that comes up. I've seen it come up in conferences and things like that, of platform versus point solution. Mm-hmm. As we move into this era of being able to connect into different ecosystems, like, should we be focused on should digital health companies, and you're an investor in a lot of these scenarios and a creator, so should the focus of an entrepreneur or an innovator be on doing one thing extremely well, or building out a platform that answers a bunch of different questions? Platform versus point solution. Where do you fall on that spectrum?
I hope my answer doesn't sound overly sort of like a lawyer or a consultant or something, but I think they both have their place. And we see ourselves from a health system perspective as a platform as well as a provider, right? Platforms really integrate between all of the different sort of providers, and we see ourselves as both, right? And in many cases. But when it comes to entrepreneurs and the work that they're doing, I think there's value in helping us connect the dots as well in a lot of different areas. And when we, for instance, like from a digital innovation perspective, build, a lot of what we build is platforms that then we make available, because we see so many bits and pieces, but they don't talk to each other. They don't, they're not all kind of rowing the same direction as it relates to a specific targeted outcome or set of outcomes. So that's helpful to us. And in some cases, it's actually better because you're not saying, hey, we're going to rip and replace something. What we're going to do is we're going to get value out of the thing you already have. Right. So that's got its place. In some cases, a point solution is super valuable. We're not experts in everything. I would almost consider like lab as a form of a point solution, specialty pharmacy as a form of a point solution. There is, solutions in mental health, point solutions. They all have their place too. And I would say the first place to go is, does it solve a big problem? And then you can go from there, right? And it's an extremely target-rich environment when it comes to big problems.
Excellent, excellent. Thank you. I have there's one that just came in. It's a bit long of a question, but how about this? How about this? Last time you were on our show, we gave you a magic wand, and you were able to cast a spell to change one thing about healthcare. I went back and dug back what your previous answer was, and you said if I could use this magic wand, I would give everybody a sense of urgency about solving solving the big problems within healthcare. Urgency to solve our patients' problems, recognizing that zero harm doesn't just mean not making clinical errors. It means making care accessible and affordable for everyone. That's the picture of zero harm you want people to coalesce around. Look at you. Mm-hmm. You're like not in that, like you spoke so well, and now you're being reminded that, oh, I said that.
I'm consistent.
But it's true. It's true. Look, it's so good that you're hearing it again. But like, we got to give you the magic wand, and you can't. I just gave you that answer, so you couldn't say the same thing again. So we're giving you the magic wand. What's spell number 2?
I'll take a different approach because I focused on sort of what we can do, or like what sort of mentality we as providers kind of need to espouse. I'll take an outcome-based approach, which is we need to make care affordable. That would be the one single thing that I would do. And now that's obviously like, you don't just lower price, right? Because then providers are in a tough spot. Like there's a whole system that works together to make sure that care is or is not affordable. And that would be like the number one priority. As a system, as a country, I think that is an absolute like top 3 imperative.
Well, that serves as a powerful gold standard and guiding light to a lot of the policies, and a lot of things, like a lot of the operational efficiencies that you're talking about can rise by this interoperability. And it leads to another question. It's the final question. Like that was supposed to be the final question, but
okay.
I'm just being honest. I'm just being honest. I asked that question so I could. I didn't want Mark Pitts to feel like he was isolated because he asked a longer question. So I did use that time to read this question, and it's a good one because he questioned. Like, are there mandates and things like that at the federal level, such as national patient ID mechanisms and things like that, that would be attached to healthcare data? Like, he was basically asking about your perspectives on what kind of role those might play into solving this interoperability picture.
I think it's going to be really probably politically untenable to have a national patient identification system. So that's unlikely to happen. But I think the more standards-based and open standard-based approaches that we can have the federal government push on, I think that will be, that's probably, that's a super important building block. And then you can effectively have like almost like a de facto patient identification system, leveraging OIDC and other things. So I think that's an OIDC, for folks who don't know, is OpenID Connect protocol. Yes, that's right. OpenID Connect. That's right. So like with that in mind, that's what I would say is like you can create a de facto system if you've got the proper standards in place.
Well, and following up to Mark's question, like how the specifics on what rolls out and what happens, I'm nowhere near even partially one quarter of an expert. But I do have some optimism coming from the fact that at the top, that conversation with Mickey Tripathi, which we haven't posted
Yep,
yet, but we will, keep an eye out for it. And to hear from him, his support for these types of initiatives gave me a lot of hope and influenced a lot of the
absolutely.
questions. Yeah. Well, Sara, it was so good having you a second time. We've had some questions like, do we bring on a second? Well, nah, third time. Third time will be a charm, okay? Hopefully.
I
I
love
don't know. I'm
it.
speaking on your behalf if you're okay coming back.
I love it. I love it. It's always a pleasure. Thank you for having me.
No doubt, no doubt. And for the people that want to follow, keep in touch, see what you're doing and understand and learn, what's the best way to do that?
You can find me on LinkedIn or one of our Providence Digital Innovation or other team sites. I try to keep current with like what we're doing and what the team is up to and our priorities. Providence's LinkedIn is also a great place.
Really good reference there because yeah, again the work that Sara is doing is multifaceted. So if you're looking to follow more on the innovation front versus another front, then she's outlined some ways that you can do that. As for us, we make it easy to follow Meeting of the Minds as well. And one thing that this conversation really made me think about was our conversation with Solomé Tibabu, who heads up the Going Digital
Awesome.
Behavioral Health Tech Conference. You know Solomé too, Sara?
Oh, I admire her from afar.
Well, come to Arizona in November, the this Going Digital Behavioral Health Tech Conference. But we actually did an episode with her that you can look up if you search. Well, you can search Meeting of the Minds wherever you get your podcast. But it's called Advancing Behavioral Health Tech by Building Community. And one thing that she's really passionate about is all these organizations, entities, vendors coming together that may or may not even be competitors, finding ways to work together. So I think it really ties into the themes that you've been preaching, Sara, about the humility to understand where your gaps are and work with, and the understanding to work with others to fill those gaps.
Awesome.
Well, thank you very much. And with that, we will
Thank
see you
you.
next time. Thank you, everybody who stayed with us today.